Up here I have Bill O'Neill and Nir Uriel from University of Chicago. We're going to go ahead and get started with a talk that's been selected from the abstracts. So this is going to be presented by Michael Cohen from the University of Southern Alabama. And the title of the talk is "To Have Clinical Value, Future Cardioprotective Interventions Must Provide Additive Protection to that from a P2Y12 receptor." Welcome.
Just for the information, University of South Alabama. So anyway, this talk is not about unloading, so you guys can all relax, and you don't even have to take notes.
Oh, you just press the green one to go forward and then to go back.
Okay, so in 1986, Murray presented a landmark study on preconditioning. And what he demonstrated is that in control hearts, he got this much infarction, but if he created a brief coronary occlusion before the longer occlusion, infarct size, as measured on the y-axis, was significantly decreased. This demonstrated that myocardial infarct size could be modified. However, it wasn't very clinically applicable because the ischemia had to occur before the long ischemic episode, not terribly effective in patients who are presenting to ERs already with their myocardial infarction. But then, subsequently, Vinton Johansson's lab established another paradigm, and this was postconditioning, in which the brief coronary occlusions occurred after the long ischemic episode, and this created as much salvage as did preconditioning. So this was actually very exciting because this could indeed be used clinically. And in fact, a group in France, Ovisa's group, did this in people. They did post-conditioning with 4 brief episodes of ischemia, with 4 brief episodes of re-occlusion following the main PCI, interspersed with 1-minute periods of reperfusion. And this technique, this post-conditioning, created a fair amount of protection. Infarct size measured on the y-axis and ischemic zone size measured by ventriculography on the x-axis. And you can see that those individuals having post-conditioning had a fair amount of protection, so that for any given ischemic zone size, infarct size was actually much smaller. Having said that, and this was a study that was done in 2005, and the patients with large ischemic zones actually benefited the most. Having said that, though, this is that study from the French group, but subsequently, virtually all studies demonstrated very marginal protection, and all of the recent studies have shown virtually no protection from ischemic post-conditioning. And so one might ask, why is this? What has changed? And in the study by the French group, only about 25% of their patients were on a P2Y12 antagonist, and at that time that was clopidogrel. And so we asked that group if they could look at their patients and stratify them according to use of that antiplatelet agent. And so, because we wondered, could platelet inhibitors be post-conditioning the heart? And so this is that reanalysis of those patients, and you can see here these are the control patients, and then those patients that either had only P2Y12 inhibitors or only post-conditioning only had very marginal protection. But if the post-conditioning and the P2Y12 clopidogrel patients, if the patients received both post-conditioning and clopidogrel, you can see now there was a very marked protection. So that in those results from the French group, the data were really driven by this group. And it should be pointed out that as I mentioned, only 25% of their patients received the clopidogrel, and also most of those patients received an inadequate dose. So that there happened to be this additive effect, but it was probably because each of these interventions was at suboptimal effect. But here's a population study showing that clopidogrel was very protective in patients with STEMI, and the assumption was always, at that point anyway, that protection was caused by prevention of intravascular thrombi during and after PCI, but this is exactly what we would also expect if the clopidogrel was an infarct-reducing agent. So our question was, do platelet inhibitors reduce infarct size in animals? And so we used as our P2Y12 antagonist Cangrelor, which is an intravenous preparation, which makes it much more suitable for animal experiments. And here you can see the control group, and this happens to be in open chest rabbits with the infarction nearing 40%. When we gave Cangrelor just a couple of minutes before reperfusion, you can see that the infarct size was halved. But I want to point out that the Cangrelor had to be administered just before reperfusion. If we gave it as late as 10 minutes after reperfusion, the protection was already gone. So delaying the start of postconditioning aborted protection. So does Cangrelor protect by a postconditioning mechanism? And this is a rather complicated slide showing the signaling pathway in conditioning, but I want to point out 6 of the steps involved. The mitochondrial KATP channel, the oxygen radicals that are produced by and released by the KATP channel, adenosine A1 receptors, adenosine A2B receptors, and the kinases ERK and PI3 kinase. These 6 steps we targeted with specific antagonists to see what would happen to the Cangrelor's protection. And here is the results of these experiments in rabbits again, the control group, and you can see Cangrelor very protective. And each of these 6 steps, when blocked, aborted protection. The same result that you get if you use these antagonists in either a preconditioned or a postconditioned model. So we felt that this was like the fingerprint of conditioning, and so we considered Cangrelor to be triggering the same conditioning pathway as preconditioning and postconditioning. And it's important to point out that none of these agents, even though they blocked protection, interfered with Cangrelor's inhibition of platelet aggregation. Protection was from the protective signaling then, rather than an effect on thrombus formation. And I want to point out, this is an important observation, when we combine the Cangrelor with either ischemic postconditioning or ischemic preconditioning, you can see there was no additive effect. So that the Cangrelor in these series had already maximized the conditioning effect. So if you added a second conditioning agent to the mix, there was no effect because the conditioning effect had already been maximized. So that if we want to create an effect, we have to use something that has a mechanism other than the conditioning mechanism. So we asked, what is Cangrelor's target? And this is the control and the Cangrelor groups. You can see with showing the protection. And what we did is we used an antithrombocyte serum to deplete platelets. And this was done in rats, and we depleted platelets by 96%. And you can see that in the rats, with just platelet depletion, there was no effect on infarct size. But now when we depleted platelets and gave Cangrelor, we also lost the protective effect. So this suggested strongly that the Cangrelor was dependent upon platelets. And I should also point out that in an isolated heart where there are no platelets, Cangrelor is not protective. So Cangrelor must be targeting the platelets, and even though platelet depletion aborted Cangrelor's effect, you can see that ischemic preconditioning was still effective because ischemic preconditioning is not dependent upon the platelets. So the ability to mimic postconditioning seems to be a class effect, as identical protection was seen with clopidogrel and Cangrelor, two other P2Y12 antagonists. The strength of protection is strongly correlated with how much platelet reactivity is lost, and whether glycoprotein 2B3A inhibitors are also protective is unknown, but clinical studies would suggest they are. There was a recent clinical study examining the effect of cyclosporin. This was a multi-center study done here in Europe, the Circus trial. And cyclosporin is a post-conditioning agent. And so this time, the French group was giving the cyclosporin to patients with STEMI. Now, by this time in 2015, all patients are being treated with a P2Y12 antagonist. And you can see that the cyclosporin had no effect, no clinical effect, nor did it have any effect on infarct size. So that in this clinical study, where patients are already post-conditioned by having received their P2Y12 antagonist, adding another post-conditioning agent is ineffective. So the current standard of care is a loading dose of a P2Y12 drug prior to reperfusion therapy, which post-conditions all patients. Even with platelet inhibitors, though, 25% of AMI patients with an LAD thrombus will die or develop heart failure within a year. We clearly need more protection. Any clinically useful cardioprotectant must be able to further reduce infarct size in a P2Y12 treated heart. Are there any interventions that could add additional protection to that from a platelet inhibitor? And here's a study done in rats where we used 3 different interventions. The one intervention was Cangrelor, the second intervention was cooling, hypothermia, and the third intervention was cariparide. And cooling and cariparide have different mechanisms than conditioning. Each of them is not useful when given at reperfusion. It has to be given at the beginning of ischemia. So we know that the mechanisms are different. So this is the control group. And here, these lines represent the relationship between infarct size and risk area when each of these 3 is used individually. So Cangrelor, cooling, and cariparide, when used individually, basically had the same effect. Now, if we use double protection, so we doubled up Cangrelor and cooling and Cangrelor and cariparide, you can see that there was a marked increase in protection. And likewise now, we use triple protection. We used all 3 of these, and we got very small infarcts, suggesting that if we can find the right interventions, we can increase the expected protection from Cangrelor, or from a P2Y12 antagonist. So in conclusion, AMI patients treated in timely fashion with P2Y12 antagonists prior to emergent PCI are already beneficiaries of post-conditioning and are, quote, protected, end quote. Infarction, however, is not eliminated. A second cardioprotective intervention with a different mechanism of action can be administered at reperfusion to provide additional protection. In all preclinical models of ischemia reperfusion, any intervention being investigated for its cardioprotective qualities must be evaluated in the presence of P2Y12 blockade to determine whether the second intervention's protection is additive to that of the antiplatelet agent. Thank you.
Great. That was a terrific talk. Thank you very much for that contribution. We have time for a couple questions. Derek?
Thanks, Mike, for that great talk. So if you're postulating a P2Y12 inhibitor is postconditioning, but in STEMI patients who have oral inhibitors of the platelet, the P2Y12, it takes 4 to 6 hours for the drug to be absorbed. And so by the time you could have targeted reperfusion injury, the drug wouldn't be on board the P2Y12 inhibitor.
What was the question?
So you're saying that because the patients are having oral P2Y12 inhibitors, the STEMI patients,
Yes.
but it takes 4 hours plus for the drug to reach
Right.
therapeutic levels, and by then the reperfusion injury has already occurred. So how do we know that that's causing a postconditioning effect in the clinical setting?
I mean, this is obviously an important question when it comes to treating those patients with acute MIs that get into the ER, because that's when many of them first get exposed to the P2Y12 antagonist. And although the use of clopidogrel is going down, Cangrelor is still an oral agent, and its absorption, as Derek mentioned, its absorption takes several hours. Not only because it's an oral drug, but also because these patients are being treated with morphine, which slows down gut motility, and absorption is further decreased. So that a lot of these patients receiving the oral agent 30 to 45 minutes prior to their PCI are not really being protected by that P2Y12 antagonist. So that if we really want to protect these patients, we either have to give them their P2Y12 antagonist hours before their PCI, which obviously is not feasible in these patients who come into the ER, or we really have to give them an intravenous preparation like Cangrelor. And I think that this will be one of the reasons to promote the use of Cangrelor in the cath lab to give them that protection, because Cangrelor's effect appears within a couple of minutes. And so that after you give the intravenous preparation, the intravenous Cangrelor, you get protection within a couple of minutes, and then you can have a constant infusion for a number of hours until the oral preparation is having an effect.
This is a wonderful, wonderful lecture, and I have one comment and a question. The comment is that I did a bunch of work with cariparide, and there was no proof that it ever, in humans, that it decreased infarct size, but in your model, it does, cariparide alone does cause a modest reduction of infarct size. So there's a discrepancy between your model and what we've seen in the clinical arena. And the question is, you know this literature incredibly well. Today, would you advocate doing this remote ischemic conditioning, blood pressure cuff, 5 minutes and off, en route to the cath lab? Is that something that has, with everything you've seen, all the trials, all the basic data, is that something that you would advocate doing today?
Okay, first with the cariparide, when used clinically, the cariparide was not given before ischemia. That's when it works in animals. If it's given later, it's ineffective. And there were a couple of surgical trials where cariparide was given before the surgery, and there was some quasi-protective effect. But anyway, in the second one, with remote preconditioning, I think Derek is going to mention that a little bit. The literature on remote conditioning is mixed. It's confusing. And so I think there are a couple of big trials going on of remote conditioning in STEMI. And I would say, rather than sticking my neck out, I would say let's wait a year before, and then see those results.
Thank you very much.